right, now we're going to talk about the cardiovascular system. And as you can see, we have a picture of a square heart here. All right, now I know you didn't know the heart is square, but it is. You've got to understand the normal blood flow through the heart, and I have that written out in your packet somewhere, okay? But here, just listen to me for a second, okay? Blood comes from the venous system, okay, and comes into the right side of the heart. And you know, the amount of blood coming into the right side of the heart, that's your preload. The amount of blood coming into the right side of the heart is preload. And it goes right atrium, right ventricle, down into the lungs where it gets oxygen. Then it goes back way over here to the left side of the heart. The left side of the heart is the big bad pump. Okay, that's the strongest part of your heart. It goes left atrium, left ventricle, and out through the aorta, which is the first and largest artery in your body. First and largest artery in your body, and then the aorta, it's the beginning of the arterial system. Arteries go throughout the body delivering oxygenated blood, and when all the oxygen has been pulled out of the blood, it ties back into the venous system and the process starts all over again. Okay? Now, if you have got, just look at the right side of the heart for a second. If you have right-sided heart failure, what does that mean? Right-sided heart failure means that the blood is not moving forward. All right? So if you look at the picture, if the right side of the heart normally pushes blood forward into the lungs, doesn't it? By looking at the picture. However, if it's failing, blood's not moving forward, so it's going to start going backwards into what system? Venous system. You see, some people think, well, the right side of the heart's failing, so the blood's going to back up to the left. That can't happen unless you have a hole in here somewhere, in between the septum, in the septum that's separating the right and left side. Now, look at the left side with me for a second. If the left side of the heart is not pumping properly, if you're going into failure, that means blood's not moving in what direction? Forward like it should. So it starts going backwards into my lungs. So that's why you've got to understand the normal blood flow of the heart, or you'll never understand right and left-sided heart failure. Now, also you have on your handout how to assess cardiac output. Cardiac output is one of the most important assessments you will do. And I've got your formula out there. Cardiac output equal heart rate times the stroke volume. Okay? And if you don't understand cardiac output and heart rate and stroke volume and how they're all intermingled together, we have two little sections there written in italics that you can read sometime, okay? That's if you want to understand that more. That's an excellent way to help you understand what's going on, okay? Now, I'm going to talk just in general about cardiac output. So come on down where it says, if your heart is weak, what will happen to cardiac output? Increase or decrease? Decrease. If your cardiac output is decreased, will you perfuse properly? No. Will you perfuse your brain very well? No. So your LOC is going to go down. Will you perfuse your heart very well? No. So your patient's going to start complaining of chest pain. Will you perfuse your skin well? No. So how's the skin going to feel? Cold and clammy. Well, if the blood's not moving forward, it's going to back up into my lungs, so now I have wet lung sounds. If I'm not perfusing, what's going to happen to my peripheral pulses? Decrease, maybe even be absent. Am I going to perfuse my kidneys? No, so my urine output's going to go down. All right, from this point forward, when you think about cardiac output, I want you to think left ventricle. Think left ventricle. How much blood that left ventricle is pumping out to the body. Now, before I read the next sentence, let's pretend that my heart rate all of a sudden, for whatever reason, dropped to 30. Am I pumping out as much volume out here to my body as I used to? No. So what's right then, what is going to happen to my blood pressure right then? Drops, because less volume, less pressure. But I have compensatory mechanisms that kick in, so later my blood pressure will hopefully come back up to at least 90, I hope, because you've got to have at least a 90 blood pressure to perfuse vital organs, don't you? Yes. So initially, blood pressure drops, but the compensatory mechanisms kick in and bring it back up to 90. Now, before we move on, there are lots of things that can affect your cardiac output. Let me just talk. This isn't on your handout. I'm just talking now. Well, we've already said that if your heart rate drops out the bottom, cardiac output just went down. What if for some reason my heart rate jumped up to 250? Watch my heart. Do my ventricles have time to fill? No. So extreme tachycardia, cardiac output just dropped. Now here's my rule with arrhythmias. Here's the rule. Arrhythmias are no big whoop, W-H-O-O-P, until they affect your cardiac output. Arrhythmias are no big whoop until they affect your cardiac output. Nobody even cares about your arrhythmia that you're walking around with until your cardiac output is affected. Now, y'all, this is why, that sentence that I just said is why V-tach, V-fib, and asystole are big whoops. Because when you have V-tach, V-fib, or asystole, do you have any cardiac output at all? None. That's why they're big whoops. You could have a patient in one room in atrial fib, and they're sitting up in the bed flipping the remote, oriented ×3, skin warm and dry, good blood pressure, etc. Are they tolerating their rhythm? Yeah, so it's no big whoop. But this person over here goes into atrial fib, and they get all confused. Their lungs get wet, they get cold, their blood pressure drops. Are they going to be able to stand it? No. So my point is this. If you ever have to call a doctor about a rhythm change or anything heart-related, the first thing they're going to want to know are these things we have listed on your handout. The signs and symptoms of adequate cardiac output. That is your pertinent cardiac assessment that they want to know about. All right, now then, let's look at chronic stable angina. Chronic stable angina. Yes, the long-term blood pressure. Okay, let me say it again. When cardiac output drops, okay, that's when you don't have as much volume coming out here, so less volume, less pressure, blood pressure drops. But long-term, you know, when the compensatory mechanisms kick in, that's when your blood pressure should come back up. We hope it comes back up to at least 90. All right, now then, let's look at chronic stable angina. This is decreased blood flow to the myocardium, which leads to ischemia or necrosis. Which one is it? Ischemia, which leads to pain and pressure in the chest, and it's usually caused by coronary artery disease. Now, what brings this pain on? Low oxygen, usually due to exertion. Low oxygen, exertion. And what relieves the pain? Rest and or nitroglycerin. Rest and or nitroglycerin sublingual, we're talking here. So let's talk about nitroglycerin a little bit. It causes venous and arterial what? Yes, dilation. Vasodilation. And this result will cause decreased preload and afterload. Well, that's good, because if you can decrease preload and afterload, what did you just do to workload? Decreased workload. That's very important with heart people, to decrease workload. Nitro also causes dilation of coronary arteries, which will increase blood flow to the actual heart muscle, also known as the myocardium. That's good. We want to get more blood going to the heart muscle, because if you can get more blood going to the heart muscle, that blood's going to take more what with it? Oxygen. That's what the heart needs. Take 1 every 5 minutes times 3 doses. And teach the client to remove the cotton from the container as it absorbs the drug. Is it okay to swallow your nitroglycerin? No. You know, absorption is different in different parts of the body, isn't it? We want it under the tongue for rapid absorption because under the tongue is very vascular. Keep in a dark glass bottle, keep it dry, keep it cool, and it may or may not burn or fizz. Y'all, the usual thing we think of here is this. When you put nitroglycerin on the tongue, we tend to want it to burn because we know that means it's new and in date and it's fresh. Okay? If it doesn't burn, depending on the drug that you're on, it may be out of date. But not all nitroglycerin products will burn. It just depends on which one you're on. The patient will get a what? Headache. Renew how often? Every 6 months is average. And after nitroglycerin, what do you expect the blood pressure to do? Drop. But let's think NCLEX, y'all. When you give somebody nitroglycerin, I know their blood pressure is going to drop because it vasodilates them. And then we always come back in 5 minutes and recheck their pressure and see how their pain is. On this test, though, you never leave the patient because when you're messing with somebody's blood pressure, are they stable or unstable? Unstable. You've got to stay with them. You've got to forget what you've seen done at the hospital. Yeah, their blood pressure's supposed to drop, but it's supposed to come back up. In some people, could it just keep on bottoming out? That's what we're scared of. That's why they want us to stay with them, to make sure it does come back up again. Beta blockers are given, okay? We've listed for you several examples there. What do beta blockers do to blood pressure, pulse, and myocardial contractility? Decreases. And what does this do to the workload of the heart? Decreases. Calcium channel blockers. If you had to guess, what would you think that these did to the blood pressure? Decreased it. Because you're never going to give a heart patient something to pump up their pressure, now are you? No, you're going to throw them into an MI. Now put a star by the next sentence. They also dilate coronary arteries. That's a good thing. Enhancing blood flow to that heart muscle. And also, our chronic stable angina patient may be put on aspirin. That just has an antiplatelet effect, doesn't it? Patient education is next. Avoid isometrics. Those are exercises that make your muscles squeeze or tense up, like lifting something. Avoid overeating, rest frequently, avoid excess caffeine or any drugs that increase the heart rate. Wait 2 hours after eating to exercise. Dress warmly in cold weather, but any temperature extreme can precipitate an attack. Hot weather too, right? What if your angina patient drinks a big tall frozen strawberry daiquiri really fast? Could that precipitate an attack? Yes, any temperature extreme. Take nitroglycerin prophylactically. You know, these people learn when they're going to have chest pain. If they see a flight of stairs, they know if they go up that flight of stairs, they may have chest pain. So they need to sit down and take their nitroglycerin, don't they? Why do I say sit down and take the nitro prior to walking up the stairs? What's the deal with sitting down? I'm going to get dizzy, aren't I? Yeah, I could fall. That's a safety issue. Stop smoking, lose weight. Smoking cessation is very, very, very important. The number one thing to remember with this person is to do everything you can to decrease the workload on the heart. All right, now we have acute coronary syndromes like MI or unstable angina. You know, as your angina gets worse, it gets more unstable, more unpredictable. You used to know what was going to bring your angina on, but the closer you get to an MI, the more you don't know what's going to bring your angina pain on. Now, this is decreased blood flow to the myocardium, which leads to ischemia, necrosis, or both. Both. You have both ischemia and necrosis here. Now, does the patient have to be doing anything to bring this pain on? No, they may be asleep. I bet your teacher told you that a lot of MIs occur in the early morning hours, right? Yeah, when people are coming out of REM sleep. When you're coming out of REM sleep, that's a very stressful time, and so a lot of people have MIs during that time, okay? Now, will rest or nitroglycerin relieve this pain? No. So signs and symptoms, pain. The classic picture, pressure in the chest. Pressure, pressure, pressure. With radiation to the left side, right? Yeah, radiation to the left side. But you know, everybody's different. Some people may just have pain in the left jaw. Other people have very atypical signs of an MI. I've seen women that presented to the ER and the only thing they were complaining of was back pain. I saw a gentleman one time that the only thing he was complaining of was bilateral elbow pain. It was full-blown MI. Or you see people that just have indigestion, or people that faint, okay? So the classic picture is the pressure, okay? But there's other ways people can present too. All right. Now, cold and clammy and the blood pressure's dropping. Well, if you see any of those things, I know that my cardiac output is going down. White count and temperature are increased due to inflammation. EKG changes. Yeah, your heart is irritated, isn't it? Very irritable, and vomiting can occur. Anytime you have somebody in tremendous pain, they may start to vomit. Because when you're in a lot of pain, the vagus nerve can be stimulated, which drops your heart rate. And when you've dropped your heart rate, you don't have blood going to your GI tract, so people get nauseated and they begin to vomit. Now, what are the cardiac enzymes that are drawn? Well, it must be the CPK and the LDH. But what do we call those things that I have in parentheses? Isoenzymes. Those are the isoenzymes. You've got to have the isoenzymes, because if you just get the CPK and the LDH, that's not going to do you any good. Now, which isoenzyme is the most sensitive indicator of an MI? CKMB. That's an isoenzyme, CKMB, because that means heart muscle is damaged. Heart muscle is damaged. Now, we also have the troponin there. Now, this is my favorite heart test of all. Cardiac biomarker, cardiac marker, it's sometimes referred to. Now, the reason it's my favorite is because it has a high specificity for myocardial cell injury. It's always normal in non-cardiac muscle diseases. You see, y'all, with the CPK, if you've been giving me IM injections, that can make my CPK go up. Nothing else can make your troponin go up except heart stuff. That's why it's our favorite. Elevates sooner and stays elevated longer. Can be detected 3 to 6 hours after onset of chest pain.